Our initial clinical question was what interventions reduce the risk of contracting a urinary tract infection?
Our searchable question was, does the use of sterile technique when inserting a urinary catheter cause less urinary tract infections in hospitalized patients than when using clean technique?
Our PICOT statement is as follows. P is for catheterized patients in hospitals. I is for sterile technique with catheterization. C is for clean technique. O is for reduced number of UTIs. And T is while hospitalized.
The category of our research is therapy because it focuses on the effectiveness of the intervention, which was sterile technique, in the prevention of urinary tract infections, because the clinical outcome is observed over a clinically significant period of time.
Our conceptual definitions for our PICOT statement are as follows. According to the Gale Encyclopedia of Medicine, the conceptual definition of urinary catheterization is urinary catheterization is the insertion of a catheter into a patient's bladder. The catheter is used as a conduit to drain urine from the bladder into an attached bag or container. Our other conceptual definition is for aseptic techniques. According to the Mosby's Medical Dictionary, the conceptual definition of aseptic technique is any healthcare procedure in which added precautions such as use of sterile gloves and instruments are used to prevent the contamination of a person, object, or area by microorganisms.
The database that we used was CINAHL. The subject heading we used was urinary catheterization with keywords sterile technique in quotes. This search produced 6 results, and out of those, 2 of them are related to our PICO project. We modified our search strategy with Gary. We kept our subject heading as urinary catheterization and changed our keywords to infection control. This produced 129 results, which was quite a lot. We could have put restrictions on this search to narrow it down, but the first couple articles were very pertinent to our topic.
The title of my article is Nurse-Directed Interventions to Reduce Catheter-Associated Urinary Tract Infections. The purpose of the test was to test the impact of nurse-driven interventions based on current evidence to reduce catheter-associated urinary tract infections in hospitalized patients on 2 medical/surgical units. The article provided level 3 evidence. It was a pre-test, post-test design, which is a type of quasi-experimental design.
The title of my article is Intermittent Catheterization in the Rehabilitation Setting, a comparison of clean and sterile technique. The purpose of my study was to compare the onset of symptomatic urinary tract infection in individuals with spinal cord injury in a rehabilitation setting who are randomized to clean or sterile intermittent catheterization. The type of design my study provided was a randomized controlled trial, which was level 2 evidence, and the setting of my trial was in a spinal cord rehab unit.
The title of my article is Preventing Catheter-Associated Urinary Tract Infections in the Zero Tolerance Era. The level of evidence that this article provides is level 3 evidence because it is a quasi-experimental study involving multiple interventions to reduce the incidence of catheter-associated urinary tract infections. It was conducted in 2 different settings, a medical surgical unit and 2 step-down units.
The title of my article was Indwelling Urinary Catheter Management and Catheter-Associated Urinary Tract Infection Prevention Practices in Nurses Improving Care for Health System, Elders, Hospital. This article provided level 6 evidence because it was a single qualitative study in which electronic surveys were used to determine the types of interventions used in 75 acute care hospitals in the Nurses Improving Care for Health System, Elders system. The use of nursing interventions caused a decrease in days a catheter was used, but was only statistically significant on a medical floor, not a surgical floor. In 2 of our articles, although the findings were not statistically significant, they were significant findings in clean technique being cost-effective.
There were a few overarching limitations between our 4 studies. The first limitation was that the findings were not generalizable to other hospitals, which causes a threat to external validity. There was also a threat to internal validity because they did not incorporate physicians that were in charge of controlling when to use catheters. The study did not give the physicians adequate education like they did for the nurses in the study.
Another limitation is that 3/4 of our articles were not randomized.
The quasi-experimental interrupted time series was another limitation because it raised the incidence of mortality.
Okay, sorry. The strengths that we found for all of our articles were that they had multiple interventions that were tested, and in 2 of our articles they used 2 different settings to test interventions, providing a broader spectrum for the experiment.
2 other strengths that we found were one article promotes the cost effectiveness of the clean technique, and time series designs were used for the 2 quasi-experiment designs, which give data for before the intervention and after the intervention. The overall conclusion regarding the strength and consistency of the evidence in our articles are our articles all provided us with weak grade I recommendations based on the U.S. Preventative Service Task Force after May 2007. It is found in our book on page 398. After analyzing our research articles, a recommendation that we found was a prevention for catheter-associated urinary tract infection should be used. However, our articles do not provide any statistically significant evidence stating that sterile technique prevents urinary tract infections. Therefore, we cannot specifically recommend a specific type of intervention.
As previously stated, our articles do not provide us with any statistically significant findings related to the use of sterile technique in preventing urinary tract infections over clean technique. Therefore, we suggest that you continue following policies for urinary catheterization in your healthcare institution.
Our suggestions for policy, staffing, and financial implications is as follows. Education was a very important intervention used in many of our studies, but physicians and nurses must be involved in the education programs. There are a lot of intervention policies that have already been integrated into hospitals, but all healthcare facilities should be required to have these policies.
Our future research question is, how do education programs alone affect the incidence of UTIs in healthcare settings? More studies should focus on the question of if sterile technique alone helps prevent catheter-associated urinary tract infections in inpatient settings.
Now we're going to compare and contrast our 4 articles. My article used qualitative and quantitative surveys to gather data about the different types of interventions that hospitals use when giving catheters.
Whereas Allie and my experiments were quasi-experimental designs, and they used 2 settings, and the materials that we used were...
Some of them were tools. Some of the tools that we used were bladder scanners, nurses report, and self-report on infections. Mine also used urine analysis to determine the microorganisms that were present in the urine to see if an infection was present. And our articles also had a pre-intervention design or experiment and a post-intervention experiment.
This allowed us to collect baseline data before they compared and contrasted the differences of intervention outcomes.
Whereas my article was a level 2 evidence randomized control trial, which used a chi-square test to analyze all of the findings, and it used urine analysis to determine whether or not patients actually had a urinary tract infection.
In reference to our research question, all 4 of our articles did not provide statistically significant evidence showing that sterile technique is a better form of infection control than clean